Welcome back, clinical problem solvers. This is Sid, a current fourth year medical student at UCSF, and today I am super excited to talk to you about a schema for acute pancreatitis. As a side note, we will not be covering the chronic form of the condition in this talk. Let's start by talking about the diagnostic criteria for acute pancreatitis. In order to make a diagnosis, we need at least two of the following three criteria. The first is upper abdominal pain, which is often described as epigastric pain due to the anatomic location of the pancreas in the abdomen. The classic teaching is a patient that presents with epigastric pain that radiates to the back. However, it is important to acknowledge that radiation to the back is often absent, and that the pain can present anywhere in the upper abdomen, including the right upper quadrant and less commonly in the left upper quadrant. The second criteria is an elevated serum lipase level, above 3 times the upper limit of normal. Pancreatic acinar cells normally produce digestive enzymes such as lipase. These enzymes leak out into the blood during pancreatitis and can be measured. Amylase can also be elevated, but it is not as specific for pancreatitis and can be seen in many other common conditions, such as cholecystitis and alcoholism. Lipase is also more reliable in detecting later presentations of pancreatitis, given its longer half-life when compared to amylase. The third criteria is CT scan findings suggestive of acute pancreatitis. A CT scan with contrast is also useful for detecting local complications from the disease, such as pseudocyst or tissue necrosis. Remember, we only need two of these three criteria, and in a large fraction of patients, the pain and lipase clinch the diagnosis, with CT being reserved for only a minority of patients. Let's now transition into our next topic, the most common etiologies that cause the vast majority of pancreatitis. The most common cause is gallstones, which account for about 40% of cases. If we look at this image, we can see the pancreas that contains ducts, which drain pancreatic enzymes into the adjacent duodenum. You can also see the gallbladder, which drains bile into the duodenum via the common bile duct. This is why a gallstone that leaves the gallbladder and becomes lodged distally at the ampulla can block the outflow of pancreatic enzymes into the duodenum, which is thought to result in autodigestion of the pancreas and pancreatitis. Given the base rate of gallstone-mediated pancreatitis, patients with risk factors for gallstone disease are inherently at an increased risk for pancreatitis. The second most common etiology is alcohol, accounting for about 35% of cases. Metabolites of alcohol can act to increase production of the pancreatic enzymes that are responsible for acute pancreatitis. This typically occurs only after many years of alcohol abuse, and usually does not occur after a single binge in a more alcohol-naive individual. The third most common etiology is idiopathic, which accounts for about 10% of cases, where an exact etiology could not be identified. Lastly, the fourth most common etiology is elevated triglycerides, with triglyceride levels often exceeding 1,000. Excessive free fatty acids are released from triglycerides by pancreatic lipase in the pancreatic capillaries, resulting in pancreatitis. Let's now touch on the more rare etiologies of pancreatitis that account for a small minority of cases. Rare causes can be categorized into structural, toxic metabolic, infectious, autoimmune, and vascular causes. Structural causes include trauma, annular pancreas, pancreatic divisum, and tumor. To reason through these, I like to relate many of the causes to gallstones and how they can structurally block the outflow of digestive enzymes. Next are the toxic and metabolic causes such as methanol, smoking, scorpion bites, hypercalcemia, and medications. Common medications associated with pancreatitis include valproic acid, azathioprine, and loop or thiazide diuretics. Infections associated with pancreatitis include hepatitis B virus, hepatitis A virus, mumps, enterovirus, leptospirosis, ascariasis, and clonorchis. Autoimmune pancreatitis is associated with high levels of elevated IgG4. And lastly, vascular causes include pancreatic ischemia and vasculitis. That was quite a lot of information, so let's take a moment to summarize. Recall that there are 3 diagnostic criteria for acute pancreatitis. Think of the common etiologies to consider if a patient with upper abdominal pain has significant risk factors for pancreatitis, such as predisposing factors for gallstones or a history of heavy alcohol use. In patients with upper abdominal pain and risk factors, send a lipase. A CT with contrast can also show evidence of acute pancreatitis along with information about its complications, but remember that you often don't need it. Remember the most common etiologies of pancreatitis, which are gallstones, alcohol, high levels of triglycerides, and idiopathic causes. And lastly, remember that there are various rare etiologies that can sometimes lead to acute pancreatitis. We hope you enjoyed the schema. Until next time, clinical problem solvers.